Okay, hi you guys. I'm going to obviously be recording this. I hope um within, I would say, after this next week I can start meeting regularly. I haven't really been able to like sit down and have some time to um have more one-on-ones, or I think like even just sit down and relax for a little bit just because of work. So they have me working like 8 to 5, which is kind of a little bit good, but in a sense, I still have other things to do outside of work. So that's kind of been a little bit of a struggle. But I do know that I'm going to be starting on my 312, so it'll be easier having at least 4 days um, like open and available, so then I can have the morning, afternoons, which all of those things and kind of dealing with a bunch of little errands, like becoming an adult, doing all those things is kind of what's taking up a lot of my time right now. But hopefully, I can kind of prioritize you guys um, a little bit more as we move forward within my schedule. So thank you for your patience and everything. These last like 2, 3 weeks, I've been feeling super busy, but at the same time, I want you guys to be able to do good. So in terms of like the exam review of what I'm going to do today, it really is just me reviewing this information with you guys, since some of you guys like, I think, the lecture and in terms of just breaking down the information. But I'm not going to be doing like an actual like exam review with practice questions. I feel like what I'm going to do is there are things that I kind of remember. I'm like, yep, you will be tested over this, or this is the things that she tested us over, and what you kind of need to know going forward. So to kind of begin in terms of the exam, just remember you will have at least one ABG. You will have I'm trying to remember. You're gonna have like at least 2 to 3 questions about dysrhythmias, EKG strips, as you guys already know. Make sure you're fully interpreting it. Um, I think she never really gave us like any of the failure to captures other than that first exam, or sorry, the exam you guys took, just going over dysrhythmias, and then at the final. But then again, anything can happen with that. And then I'm trying to think of what else. But you need to know your vent settings still. She can still ask you those things and incorporate that within other questions for sure, especially when we're talking about like cardiogenic shock, sepsis, and all of that information there. So I think I went over pulmonary embolism, but see, I think it's interesting because she had our exam information different than you guys. So you guys are going over some stuff in which like I was like, oh, that's kind of weird because she specifically went over like sepsis. Um, I think DIC hit like all together for us, but I could be wrong. It could have been something different, but I do know like the way that she cuts it off is a little bit different for each semester. So I at least thank you guys for at least sending me like what you guys are going to be tested over, so then I can go over it. So this video might be long, but again, if it's helpful to you guys, then it's helpful. But in terms of like what you need to know, I'll go over that at the end. So in case you don't want to listen to me lecture, that's totally fine. Just kind of skip to the end of this video, and then we'll go over that as well in terms of just again a summary over everything. So I'm sorry if this is a long video, but again, I want to just make sure I go through everything. Hopefully, I'm just gonna try to hit on stuff that I feel like is more important, and if you're confused about certain things. Okay, so pulmonary embolism, I went over this before, but essentially what it is I also want to apologize for all the notes that I have because this is still like from what whenever I was studying for this semester. So in terms of pulmonary embolism, it's basically just a clot, right? And then moves and then basically goes into your pulmonary system, right? Your pulmonary vessels, and now you got a pulmonary embolism, right? So usually you can start off with a DVT in your lower extremity. That's the most common. And then after that, you can end up, it moves and exports into your pulmonary system and vessels and vasculature there. So that's why it's really important that we get our patients up early. Mobility is a big thing, as well as just having those factors of like SCDs, any VTE prophylaxis, anything like that. So, in terms of your risk and etiology, really just remember it's going to be the same ones as before: genetics, a stroke, sepsis, immobility, lengthy trips, multiple traumas, surgery, fractures. Right. The weird one that I do think is kind of more of like oral contraceptives. I think that one's pretty interesting. And then I think you kind of know this because it's definitely not a good thing. Is IV drug abuse, right? And then additionally, in terms of the causes, again, it can be vegetations from the heart valves, um, fragments of clots, amniotic fluid, fragment of DVTs, fat, anything like that could possibly create an embolus. In terms of what you actually need to know, at least in terms of this part, it's more about the Varco's triad, right? So venous stasis, meaning that the blood is all staying in that spot, right? And when we know when blood is just not moving around, just like how we as people, if we're not getting up, moving around, mobilizing, then all of those blood things are going to end up clotting, right? All of those blood vessels aligning, it's going to have it trigger clot formation, and then boom, you have it. And that also could be caused by any like trauma, surgery, and then conditions like atherosclerosis when you're having a buildup of that plaque, right? So when your blood is staying in one spot for a long time, and I kind of just think about the heart valves. If one of your heart valves isn't working, it's staying in that atrium, and then it's just going to end up clotting. Right. So, in terms of hypercoagulability, that's the next one. So that's just having an increased tendency for the blood to clot, right? When we think about coagulation factors, that's kind of what, remember, coagulability is talking about. So if it's hyper, right, this is just straight up vocabulary. Hyper meaning that it has an increased tendency to do that. So yeah, things with like cancer, pregnancy, like with the amniotic fluid, genetic disorders, obviously anything genetic, and again with the use of like oral contraceptives, that just can increase your tendency for the blood to clot, right? And so if we give anything like anticoagulants, that decreases your tendency for your blood to clot. So that's why we give it in those situations. In terms of vessel wall injury, that one's just if you have damage to your blood vessel, it can trigger clot formation. Because remember, even when we're talking about sepsis, and we will talk about it today, remember, like in third, we talked about the different types of ways our body helps to fight off an infection. That includes inflammation. That includes, it does have a little bit of that third spacing with your capillary permeability. And then additionally, another big thing is your clot formation, right? So that's how, like in sepsis, we end up getting DIC, because your body's wanting to make all these clots so we can actually prevent the infection from going further because it's genuinely like a clot. And so yeah, it ends up turning into a bigger clot, and that's where you get DIC from, and it just you keep making clots and everything. So in terms of a vessel wall injury, I think you just have to think about it in the same way. If you have damage to the blood vessel, that triggers clot formation because it wants to stop that injury and minimize as much trauma as it can. So that again, caused by trauma, surgery, and other conditions like atherosclerosis. So yeah, those are the three things you definitely need to know. I think she just straight up asked us in like a multiple choice question, or select all the apply, but that's you just have to know those things, right? So venous stasis, vessel wall injury, hypercoagulability. So what I did is like I would always write it to the side and just remember that, and that's pretty much it. In terms of manifestations, I highlighted it because I feel like she did end up asking us this information. So sudden pleuritic chest pain, because remember we're talking about the pulmonary vasculature now having a clot. So if that's the case, then you're going to have that chest pain there. You're also going to have shortness of breath and hypoxemia because again that clot is changing and being lodged into a pulmonary vessel. So now you're having decreased gas exchange because of that. So that's where you get the chest pain. That's where you get the shortness of breath. And then in terms of being shortness of breath and having chest pain and that oxygenation being cut off, you're going to see hypoxemia for sure. For diagnostics, you're always like, even when it comes to like having a stroke, right? You're always doing like CTs, just so we can see what's going on, right? But really, the gold standard for a pulmonary embolism is a pulmonary angiograph. And so that makes sense, right? We're just looking straight up at the vasculature and seeing what's going on within that pulmonary system and what's being cut off. The other ones, I mean, I feel like these kind of make sense, right? D-dimer, right? That just helps to see any sensitivity to clots, but that's not conclusive of, oh yeah, we have a PE. It's just can only help further our diagnosis of that. Duplex ultrasound of lower extremities, again, because that's the most common cause of a PE. And so you can use like basically what that is doing an ultrasound with a Doppler, and that can help you see the blood flow. Ventilation perfusion scan, we talked about that more in the respiratory system, but again, seeing what's going on. Is it a ventilation problem? It's a perfusion problem. In this case, it would be more of that perfusion problem since we have that clot. And then in thus, we're not having a lot of ventilation because it's cut off. In terms of supportive testing, other things that we can help to diagnose with a PE, EKGs, right? You see some of that, checks X-ray, ABG, and you see the PaO2 there. Again, I don't think you really have to know that, but it is something to point out. In terms of complications, I think the big one for me that I had to know was right ventricular heart failure. And that again goes back to the idea of anatomy and physiology. So the veins bring back blood to the heart, right? A is for away, V is for back. So then that starts to build up, and then you have that heart failure there. Other ones kind of make sense. Respiratory distress, we already knew that. Pulmonary hemorrhage, well, yeah, because a lot of the time what can happen is you have that clot and then the blood still has to go somewhere else and now it's traveling somewhere else. Pulmonary hypertension, right? Because again, you're cutting that off in terms of the vasculature and the vessel. So now, thus, like sometimes your blood will have to increase in the blood pressure so we can get that blood through. You have pulmonary hypertension. Obstructive shock, obviously, it's an obstruction. So now you're having obstructive shock. And then sudden death, which obviously makes sense because eventually you're going to have decreased oxygenation perfusion and you need that essentially to live, right? So you guys know that. Prevention. So that's why we do the SCDs. That's why we do anticoagulants. Aspirin is an antiplatelet, but again, having to do with clots. And then treat dysrhythmias, anything that's going on there, because those can eventually be fatal when we're talking about things like VFib, um, the like third degree heart blocks, anything like that. So management, treatment, oxygen, mechanical ventilation, because obviously we're talking about a pulmonary issue. So if they can no longer breathe, you will get them ready to. You should anticipate that they're going to be intubated, right? You're not going to do the physician is, but you should anticipate that. Thrombolytics. So those are the ACE medications, right? Alteplase, all of those different ones. And then again, we have to make sure that they meet that criteria, but you don't necessarily have to know that. It's more of just knowing you're going to give that. And then again, anticoagulants, those are preventative, but we also do that in the future to help with this. So heparin, enoxaparin, warfarin. And then you guys know the antidotes for that, right? And then what we should be looking at, PT, INR, PTT, all of those things as well. In terms of surgeries, these ones are super simple. So embolectomy, that one's you're just literally surgically removing the clot, or the physician is, and so you're able to treat that in an emergency. So you can physically remove that clot with that surgery right there. In terms of the inferior vena cava filter, that one is just a small device that's placed into the IVC, and that just is used to drop those clots right there, and then it prevents that from traveling to the lung. So it's more of like I think like a preventative issue, right? Rather than something that we're surgically doing to take it out and it's already there. So if your patient knows that they're at an increased risk of having clots, maybe they have a lot of those factors. Basically, what you can do is also just end up putting in an IVC filter. Obviously, the physician's going to do that again, but they meet that criteria. They can do that as a preventative issue for that. But see, it's like super simple with this stuff. Don't overthink it. It's literally the only things that I think that you genuinely have to know is kind of just the Verko's triad. Because I feel like for me, once you tell me like, okay, there are weird things like oral contraceptives, genetics, burns, like things like that. There just are some that are weird, right? Like oral contraceptives is weird to me. Like I wouldn't have thought that. The test makes sense. I feel like you guys know this going into like all of your 3, 4 semesters. So you're like, oh, yeah, that's basically what we're talking about. Angiograph, talking about vessels. So obviously we're gonna want to see that. In terms of complications, I mean, all of them kind of make sense, right? Respiratory. I feel like if you were to be given all these options, you would be like, oh yeah, it's an obstruction, so it's going to be obstructive shock. Sudden death, well, of course, always. Respiratory distress, well, yeah. I think the only one that you kind of have to point out is like right ventricular heart failure, right? So sometimes when it comes to these diagnoses and these disease processes, I would kind of more focus on things that I would point out and just keep in mind general knowledge because there's no way you're going to remember. These were all of the complications that, she gave us. You can try to memorize that, but I feel like, again, if you just think, well, this is a respiratory issue. So yeah, you're going to see respiratory distress, right? Um, and then management treatment, you guys know those things. And then, yeah, I think the other thing is just manifestation. So that chest pain, shortness of breath, hypoxemia, angiograph, triad. That's really all you need to know for those right there. Okay. And so I'm going to pause it and then we're going to go over probably, we'll do sepsis last, I think. Oh no, we'll do cardiogenic shock next, I think. So I'm like trying to think of how I can make it all go together. Yeah, we'll do renal failure last then. Okay. Okay, so to then go over, we'll do aortic aneurysms first, and the thoracic surgeries that come with that, and then we'll go into cardiogenic shock, and then we'll get into sepsis, and then we'll get into renal failure. That is a lot of stuff, but really, I feel like because this stuff can seem a little bit confusing, that's why I can feel a little bit, I think, overwhelming and a lot to go through. But I feel like now looking back at a lot of this stuff, I'm like, oh, it wasn't terrible. But during at the time, it absolutely was. Because I feel like I knew nothing about it. And so now talking a little bit more about it, being a little bit more comfortable. And you guys will get there for sure. with those things. So, aortic aneurysm. So basically, what's happening here? We know what the aorta is, the largest artery in the body, right? It is localized enlargement. And so the problem with having an enlargement or bulging of a certain part of any vessel is that it can end up rupturing, right? And then you have a lot of issues after that with bleeding, right? So that kind of makes sense. So this specifically is saying with an aneurysm, there's something bulging out, but aortic meaning in the aorta, right? So super simple, straight to the point. So in terms of how this ends up happening, in terms of the pathway, well, if you think about it, there's a lot of weakening in the vessel, right? And then that ends up for all that blood pressure, all that blood to be going there. And if it's already weakened, that vessel wall is going to end up being super weakened and bulge out because of all the blood pressure that's happening there. So that's why it's important that we also have our vessels be strong, our vessel walls be able to handle that pressure. So basically, what ends up happening there is that that eventually can keep getting bigger, bigger, bigger. Now you got a rupture, and now you have life-threatening bleeding everywhere. So in terms of aortic aneurysms that can occur along the aorta, there's those anatomy parts, right? So you have the ascending, descending, and then that can end up varying your symptoms depending on where they are at. So the ascending, descending aorta, the thoracic region, you're gonna see that there are different symptoms according to where we're at, right? And that makes sense because again, that blood flow can change depending on where you're at, right? If I'm here in the ascending part, then we're going down my abdominal cavity, and then also your thoracic region, that ends up changing where you're going to feel some symptoms. So kind of just remember again, anatomy has a lot to do with some of the symptoms that we see, but really don't overcomplicate this. Sometimes it's kind of just understanding, oh, yeah, because this is where we're at, you're going to see this issue. So I feel like that's how I was able to differentiate it. So ascending aortic aneurysm, so which occur near the heart and extend up there up into the aortic arch, right? And again, that's just anatomy that we're talking about. So if you need to look up a picture, I definitely would recommend it. But again, this is basically going to end up, your patient's going to end up having some dysphagia. So difficulty swallowing and chest pain. So again, we're talking about the ascending aorta. So we're over here like at the top, right? Ascending aorta almost going into that, aortic arch that goes over, right? So of course you're going to end up seeing symptoms that are up here. So if I'm talking about the descending aorta, of course I'm not really going to have dysphagia if it's already down and under within my abdominal cavity and my thoracic region because that's not up here, right? So anatomy wise, it makes sense that you're going to see dysphagia more in terms of the ascending portion. So as it goes past the arch, so now we're going past the arch and now we're going to the thoracic region. You're just going to see chest pain and back pain because again, now we're going a little bit lower, so you're going to able to see that we're not having issues up here, we're having it more in the middle and lower. So chest pain and back pain, and then basically it's a little bit vague, but it worsens as the aneurysm enlarges, right? But once we keep going descending down that, so now we're past that. Now the important part is to remember the sudden, sharp, and shifting chest and back pain. I think she used another one. I think she put shearing chest pain, but that basically means the same thing, right? And so basically, once we're going toward, um, keep descending toward that lower abdomen, you're going to still see those issues of chest and back pain, but it's going to be sudden, sharp, and shearing or shifting, right? So once the aneurysm reaches the abdominal aorta, patients then have that issue. And then that ends up also indicating that there might be a rupture happening. So one of the thing that I kind of think about if you are getting a little bit confused on all of them, remember, okay, you have different regions of your aorta, right? You're ascending the aortic arch, and you're going into your thoracic region, and then you're going to go down below that within your abdominal cavity and below that regions, right? So I think in a way, all of them have chest pain. All of them have chest pain. The lower ones, so your thoracic region and then your descending, are going to end up having chest pain as all of them do, but they're also going to have back pain. The only one that's kind of different is the ascending part. Before you reach the aortic arch, is going to have the chest pain. All of them do, but it's also going to have dysphagia because again, it's in the ascending region, right? So don't complicate that. What I would just think is all of them have chest pain. The lower ones are going to have back pain. The top one, ascending, is going to have dysphagia, chest pain. And then as we get lower, it ends up becoming sudden, sharp, shifting, or shearing pain there. So just remember that. So in terms of I just kind of wanted to put this in here because I kind of had to look it up a little bit. And I remember during the time I was like, okay, I'm kind of confused. What are the differences? So because she talks about saccular and fusiform aneurysms, but that is classified under a certain type, right? So false aneurysms versus true aneurysms, and when you read it, it kind of actually makes a lot of sense. So false aneurysms basically occur when there's a tear in the vessel wall, but instead of the vessel wall dilating, the blood escapes from the artery and collects in the surrounding tissue, right? So then a true aneurysm is involved within a local dilation of an artery where all three layers of the vessel wall, and remember, like we learned about the A&P, like the intima media, all of those ones, they bulge outward, but there is no leakage, and the blood still remains inside of the artery. So basically, in the false one, there is a tear, and then that blood escapes and is now going into the surrounding tissues and all of those things, right? And then with a true aneurysm, that one is basically, well, we have an injury there, there's dilation there, same exact thing as before, and it bulges outward, but there's no actual tearage or leakage of that blood, and it's still in that artery, but hey, we still have that bulge going on, so like what's going on? So just to kind of talk about those differences in case you guys didn't know that, that's basically what it means. False means that the blood has finally escaped, there's a tear, and then with a true aneurysm, that's just basically talking about, well, it's still there, it's still bulging out, but nothing is actually leaking yet. And you can kind of read the stuff in between, but that's really all you have to know with that. So both of the saccular and fusiform, what would that go into? Well, that would just go into the true aneurysms, right? Because the blood isn't leaking outside of the artery, it's just bulging out. So when you have saccular, what that means is just that it's an outpouching of one side of the vessel. So saccular meaning like you have a sac of it, right? So just think about that. It's literally a sac. It's not going all the way around. So when you're talking about fusiform, that is a pharyngeal dilation affecting the entire vessel wall, and the vessel bulges outward on all sides. So the fusiform, I would just think about it like fuse, like it's going all the way around. It's formed all the way around that aneurysm. So saccular meaning the sac, the fusiform, if you don't really know like the verbiage, I would just think about it like it's fused all the way around. But if you also don't understand that the sac one is the sac, the fusiform is going to be the one that's all around it. And so the differences between that is you have more pressure in one spot, whereas with the fusiform, you have more pressure and bulging of the entire vessel around it, which you are also going to see that with the saccular aneurysm, you just have to think like also what the differences between those two are in terms of how you're going to see some of the changes within your patient's not symptoms, but in a way, like with a fusiform, it's going all the way around. So it's pushing other things outside of that as well, right? And then with saccular, it's just one spot where you're having a lot of pressure, and you can obviously have a little bit more of a possible rupture because it's in one spot. Where as the fusiform, it's all the way around, so everything outside of that is also having to shift with that swelling that's going on. So I think those are very interesting things that you're going to end up seeing, but those are also one of the most common types. So that's why she discusses those. So in terms of treatments and surgeries, so an endovascular graft basically is a giant stent in the aorta. So again, a stent, if you don't know it, I'm just going to read it. A stent is inserted through a catheter. Usually, it's going to be put through the femoral artery, and then it's guided into the aneurysm site in the aorta, right? Because we're talking about an aortic aneurysm. Once that stent is in position, it expands to fit into the aorta, and so basically, essentially, blood flows through the stent rather than through the aneurysm sac, so it reduces pressure on the aneurysm walls. So the way that that works is if you're looking at that stent graph. So this is, if you guys don't know what type of um, aneurysm this is, well, again, remember we said the fusiform was going all the way around, so this should be a fusiform aneurysm there. And so again, we're in the aorta. So you see we have like the ascending, you have the aortic arch, and then you're going all the way down. So that's where you see the different types of symptoms. It should actually be this way. But basically, yeah, you have a fusiform aneurysm here. And so basically what you're doing with a endovascular graft is essentially you're putting in a stent. I should do a different color. You're putting in a stent. So instead of that blood flow being able to go into here and build up here and possibly lead to a rupture and possibly then lead to bleeding, you're going to have the blood flow be controlled and then be able to go down those iliac arteries and all of those things. But the blood flow stays here, so there's less pressure over here on that aneurysm, right? So that's what we can do and is a great preventative measure of allowing the blood flow and reducing that pressure within those aneurysm walls, right? So, abdominal aorta aneurysm open repair. Dang, that is a long name, but basically, it's exactly what it is. In terms of the name, you're removing the aneurysm by replacing the weakened section with actually a graft. So, basically, what will happen? The surgeon makes an incision above or in the abdomen to access the aorta, duh, and then the aneurysm is clamped above and below the bulging section to control the blood flow. And then basically that part of the aorta is cut, cleaned out. Because again, remember what we talked about with PEs, if your blood is having if it's stagnant, not moving, if you're having that stasis there, you're going to build up those clots. So that's why they have to clean it out. And then basically the graft is inserted, it's sewn into place to remove the section, and then the vessel is sewn over it to cover it back up. And then now you have blood flow that's restored through the graft. So to kind of see more of that, so the reason why they have to clamp it above and below is so that we can obviously the surgeon doesn't have to worry about it, when they're trying to work and operate all of this blood flow that's popping out on them. They just have to do this and then they're able to do that. So um, basically, yeah, it's just clamped above and below to control that for the surgeon. And that's the graft being sewn into place. And then they can sew the artery over that. And so again, that just allows for that blood pressure, allows for that blood to be able to run through. There's less pressure in that artery as well. And then again, if you look at the artery over the aorta, that aneurysm, it's going all the way around. So I'm assuming fusiform, right? Okay. And then here's that as well in the thoracic region. So we'll talk about in terms of the thoracic surgery that's available. So again, we're talking about different regions, so abdominal, thoracic region, and essentially doing the same thing, but just in the thoracic region. So care basically that includes with the open repair includes splinting, turn, cough, deep breathe, pain management, everything that you should be doing already. Thoracic surgery, the posterolateral thoracotomy. So that is actually an open surgery to repair thoracic abdominal aneurysms. And so the incision is made along the side of the chest. So posterolateral, that's where you get that. And then basically they get access to the thoracic aorta. It's literally the same exact thing where they clamp it above and below. They put in that graft, they sew it in, and then they put the vessel over that. So it's the same exact thing. It's just, we're talking about just putting in different regions depending on where the aneurysm is at. So if you look at this one would probably be a saccular, right? Because it's not really going out and it's not forming all the way around in terms of that pressure and bulging out. So this one should just be a saccular aneurysm for that. But I hope that makes sense. I feel like, again, don't overcomplicate this issue. It's really, okay, I would just break it down like this, and I can give you like a 2-minute summary. An aneurysm. Aneurysm means that there's a bulging or enlargement going on in some type of vasculature. If I put aorta in front of it, that's going to be the aorta, right? Problem with that, it weakens the blood vessel, it bulges out, and then if it bulges out, obviously just think about anything, like when you're having too much volume or you're having too much content within your stomach or your bowels, you're going to end up having any type of rupture. If you have too much air inside the lungs, you keep giving them volume, tidal volume, they're going to blow up the lungs, right? So that we talked about that. That's barotrauma, but anything like that, if you have a lot of enlargement, if I keep blowing up a balloon, it's going to same exact thing with an aneurysm, right? So then we differ. What are the different types of aneurysms? Well, we're just talking about aorta. So what are the different types and symptoms that you're going to see? Well, you have different parts of the aorta anatomy-wise. So you have the ascending, descending, so obviously as we start up in the ascending region, then you're going to see dysphagia. In the thoracic region, you're going to see chest pain and back pain. Well, all of them you're going to see chest pain, but thoracic, that's when you start seeing the back pain. And when you start going into the abdominal region with the descending part, you're going to see that sudden shearing, sharp shifting, chest pain, back pain with that. In terms of the differences between the types of aneurysms, well, you can have the one that's all around, that's fused, so fusiform, and then you can have that one that is just like a sac, so then saccular, right? And then the treatments, you can put in an endovascular graft. So that one's basically just you're putting in the graft through usually the femoral artery. It goes into that part of the aorta, and that just allows blood flow to go through. But if I want surgery done, because sometimes it's not that endovascular graft isn't necessarily going to fix the issue, we can just go ahead in the abdominal aorta, put in the graft, sew it in place, clamp it above and below, and then you have that site, you put the vessel over it. Thoracic surgery, okay, that's the same exact thing, but just in the thoracic region, and then boom, you're done with this whole entire thing. So that's all what I would do to study. This is my biggest recommendation is I would say that out loud. Like everything that I just said, I just went over that in like 2 to 3 minutes. Obviously, I went over it for like 15, 20 minutes earlier, but really, if you're able to describe it and just go through everything in 2 to 3 minutes, don't overcomplicate it. That's kind of what I would advise to do. Because also, when you get into the final, she will ask you a lot of these questions, and there's so many of these study guides, so many of these things that you guys have to know, but if you keep doing that, I think it also helps to just be in the car sometimes and be like, okay, so an aneurysm is this, 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 and this. And then I would just like really quickly, like once I get home or wherever I'm going, I would look at it and be like, oh, I forgot about this. And then you'll remember it for next time. And that only took 2 to 3 minutes to explain. Obviously, I'm teaching it, so I have to kind of go through it longer. But really, I think ultimately my goal would be for you guys to practice just explaining it in like 2 to 3 minutes, exactly like that, after you study it. In terms of cardiogenic shock. So this one was super interesting, I think, because really the only thing I think she asked was the crap stuff. And a lot of our class got it wrong, and I'll talk about it kind of when I'm discussing that specific chart. So basically, cardiogenic shock. So the heart fails to act as an effective pump, right? That's why it's there. That's what our heart is in charge for. So you have decrease in myocardial contractility, so that you pump and everything, and now you're going to have decreased cardiac output, no blood going to everywhere, to all organs. Now you got impaired tissue perfusion. So I think you have to just remember when it comes to talking about these things, it's more about verbiage, again, vocabulary. So preload means what? So pre, before, the amount of blood filling before the heart is contracting. Afterload is talking about the pressure the heart has to overcome to pump blood out to the rest of the body. So after, pre, after, right? So but also is discussing like SVR, so that's what afterload is, and the preload, which is having that venous return and seeing how much is in the heart before that contraction. So in terms of etiology, all of those make sense, right? Any heart issue, structural disorders, MIs, contusions, cardiomyopathy, myocarditis, ruptures, so that makes sense, right? So again, not necessarily memorizing, it's just these are heart issues, you got a heart issue, you're at risk or possibly can be causing cardiogenic shock, right? So the patho within this, and to kind of understand how this works, is so the myocardium, which is the heart muscle, is damaged. So now its ability to contract decreases. It also makes sense because through time, as we get older, our muscles become dysfunction, damaged, and kind of just, you're getting older, it's just not going to work as more effectively. And so because of that, now you have decreased function. So it's the same exact thing as getting older, but basically what ends up happening with the reduced contractile force, so the way that it's contracting, beating, getting that out there, now you're going to have less of that stroke volume. So again, the afterload, the amount that's a blood put out. So as stroke volume decreases, the blood remains in the heart chambers, which also leads to increased ventricular filling pressures. Because remember that talking about anatomy there, the ventricles, no matter which one, what they're in charge of is getting that blood out to whatever they have to get out to, right? So when we're talking about the ventricles going to the lungs or then going out to the rest of the body. So with lower SV, then obviously you're not going to have a good cardiac output because cardiac output is how much blood versus the heartbeat, right? So how much blood are we getting out there? Well, if we're not getting blood out there at all because they're just staying in the ventricles, then we have less cardiac output. And so with less cardiac output, now you have less oxygenation, less perfusion going out to the rest of the body. So thus, hypotension also occurs in response to cardiac output. Now you have less adequate perfusion with the higher ventricular pressure. So again, talking about anatomy, what I talked about like 30 seconds ago, when we're talking about the left ventricle, that leads to pulmonary congestion because of the anatomy within that, right? And then shortness of breath, pulmonary edema, fluid leaking into the lung tissues, that's where you see that, right? Because again, we're talking about anatomy. You have your ventricles, they go out. You have that blood flow. Again, this is talking about the blood flow of the heart, right? And so all of that can end up leading into some type of congestion, and that's where you see a lot of these issues as well. And this also applies to like heart failure, right? So then there is decreased coronary artery perfusion to the heart itself. So now you're having less perfusion as a whole, and then also the heart still has to be perfused itself, but you're having decreased perfusion. So now the heart isn't even getting um, any type of blood flow, any type of perfusion, oxygenation. And so, as a compensation method, your heart rate will increase to try to get as much oxygen, as much blood as it can to the rest of the body. And that will also end up leading to a reduced stroke volume, lead to other issues and mechanisms like the RAW system trying to help with the hypotension, right? And then you also end up having some increased water retention, all those things because of that. So it's a lot. You don't have to know that, but I feel like the only thing that you really have to understand is just remember the things that you're going to see, right? It's the same exact thing as heart failure, but the problem with cardiogenic shock is now your heart is also not being adequately perfused. You're not being perfused at all in terms of your body. Your body's going to have to work to compensate and do all of these things with increasing your heart rate to get that blood out. And so still you're having decreased cardiac output, and so that's where you see a lot of these issues there. And then a lot of the other stuff, you're going to see it back up because it's staying in those ventricles, not getting out to the rest of the body. So your left ventricle failure systems, so then it's like, okay, you're going to have crackles, dyspnea, hypoxemia. With your right ventricular failure system, same exact thing as heart failure, GVD, edema, splenomegaly, hepatomegaly, because it's not getting out to the rest of the body, so then it's going to stay in that region, and you're having issues there within those ventricles. And then it also can end up backing up, so that's where you see those things. In terms of the rest of the signs and symptoms, I would just think about it again. You're not being perfused, you're not being properly oxygenated, so you're having cool, pale skin, AMS, increased heart rate, decreased BP, increased respiratory rate, decreased cardiac output, cardiac index. That's just having to deal with, again, cardiac output, but by the patient's body surface area, right? So somebody who's smaller versus bigger, they should have different ranges, but we keep that in mind. Angina, so chest pain, because again, you're not being properly perfused. Your body's trying to get as much oxygenation, perfusion, blood as it can. You're going to have narrow pulsing pressures and then dysrhythmias. The big thing with that to increase RAP, PAP, CVR, and then the PAOP. So that, again, that just goes into hemodynamics. But again, your body is having a lot of that ventricle resistance, so it's not wanting to get out. So of course, you're going to have a lot of that pressure there. In terms of diagnostics, I don't even want to read it because I feel like they're just kind of obvious. Echoes, hemodynamic monitoring, cardiac enzymes, cardiac cath, CBCs, chemistries, basically everything that you see with the heart and other issues that's going on, right? Um, with management. So yeah, like I would, again, all of this stuff that I talked about, that's just like kind of giving you guys some insight. But really the biggest things that you guys need to know is probably just the management within this. And then maybe manifestations and kind of with the hemodynamic monitoring things that you would see. But again, the only thing that you really have to know, everything is increased except for your like cardiac output, cardiac index. And when you're talking about sepsis, and we'll get into that, those are different. So don't get this confused. But again, if you remember the path though, all of those symptoms that you're kind of seeing is because those ventricles are having a buildup of that pressure. And then additionally, you have a lot of backup backing up, and then you see those symptoms of what's happening. And that's similar to like heart failure. So, in terms of management, know your crap basically. So, contractility rate afterload, which again is like SVR, preload, which is basically like venous return. So preload, you have to remember the three P's. So if she asks you anything about preload, if you see the P in there, you have to, you know that it stands for preload. Type in P park pump no matter what. If you type in preload, you better type P park pump right after it. So if you're gonna get anything from what I'm saying for cardiogenic shock, just please write in P park pump, because a lot of us, the way that she worded this question, it kind of made it seem like she wanted medications, like to. So I think she says this in class, but she's like, "I'm gonna give you crap, and you're gonna type in it." But the question, the way that it was worded, was like, "You want us to type in the medications for each one?" Um, so I ended up typing contractility rate, afterload, and preload. And I thought that there would be like another section where she was gonna ask like what are the three P's of preload, and then you would type it in. But she didn't. So then I was like, oh, you gotta be kidding me. And she was like, Genesis, why didn't you type in the three P's? And I was like, "Mandiola, I remember what they were. I just thought that there was gonna be another, like, section right after it that was gonna say, like, preload." And a lot of people, what they did is they put the medications, but they didn't put, like, contractility rate and afterload, that specific word, and she still gave them the credit, I think, for it. But if you notice within the medications here, some of them overlap a little bit, some of them, and really what I mean is just the afterload and preload sort of because you have kind of some of the ACE inhibitors, the ARBs. So, you could still if the question is weirded, like, not what you would have expected, just write contractility rate, afterload, preload, put those 3 Ps, the P park pump right next to it, and then if you feel like she really is asking you for medications, you can put some meds in there. Because some people did all 3, which I thought was smart, and I kind of was like, I'm pretty sure in class she said she was only gonna say she only said you have to know the names, you don't have to know the meds, but, you still have to know the meds for, like, other questions, right? So, if anything, just put all of them. Just but make sure you're typing in contractility rate, afterload, and then the 3 Ps with the preload, okay? So, if you're gonna get anything out of that, just please do that because all of us were like, "You gotta be kidding me, that was such, like, an easier question too." So that was kind of on us for not really, I think, paying more attention and looking into it too deep. So, contractility to increase the contractility, right? So, in terms of enhancing the heart's ability to pump, right? That's what we're talking about with contractility. You can give dobutamine. That is your number one choice, and that is the question that she definitely will ask you because you do need to know these meds for sure, at least for contractility. Absolutely. So, miralone, that's your second option, and then your last one is going to be digoxin. So, contractility, dobutamine, miralone. So, just know those for that, right? So if she asks you for crap, you put contractility. She asks you for the meds too. If you want to put that, you can. For us, again, she said you didn't even have to put in the meds. So I probably still would have, but I didn't because I was like, she never said that. So it depends what she told you guys, but just please write it in. And so she ended up putting or she ended up telling us later, like, a question multiple choice, like, what is the number one choice you're gonna give for contractility? And so that would have been dobutamine, right? So a lot of people put digoxin because they think that's a med you've seen like 50,000 times, and they both start with Ds. So yeah, dobutamine, um, it's I kind of think about it like do, like it has do at the beginning, so you're gonna do that first, if that makes sense. So basically, that's that. Super simple. With rate, basically, I think you kind of know these things a little bit, right? So to increase, what do we usually give to a patient like who has a decreased heart rate? Well, you can give atropine, right? That's just knowing your meds. So to increase atropine, epinephrine, obviously, to help with that. And then you're having a pacemaker because that can help with your rate. So if a patient is coming in with like those heart blocks, you can put them on um, or even with like symptomatic bradycardia, you can put them on a pacemaker and see what's going on there. In terms of decreasing, well, antidysrhythmias, because again, that helps to lower your heart rate. So then, if we're lowering that, we can also help to kind of control um, those dysrhythmias. But usually, I feel like it's more of like a side effect to that, or kind of like an enhancement to that drug, like an advantage that just so happens to be like that with a lot of anti-dysrhythmias. Vagal maneuvers, so that's not really within our scope of practice. Technically, it's more of the physician's job to do that. People still do it. I probably wouldn't. I wouldn't unless I know what my hospital's policies or procedures are. But um, yeah, so vagal maneuvers, you can see those videos online. I would definitely recommend it because it's super interesting. And so they do that, having people bear down, and you can tell a patient to do that. And then there's cardio defibrillation. So any type of you guys don't know about ACLS yet, but basically once you start working in the hospital, you guys will become ACLS certified. That's when you actually start giving the meds and stuff. So if you look up the criteria for some of the things, obviously if a patient's symptomatic, bradycardia, you can give things like epi, atropine. If they're having things like VFib, you defib, right? You cardiovert, you have different options there, but that can help with your rate. And I feel like those make sense when you think about it. For afterload, to decrease the afterload. So again, the workload of the heart, this is SVR, what the heart has to do to get that blood to pump out to the rest of the body. To decrease that, we can give nitroprusside. But the thing about this med is we're going to worry about cyanide poisoning. That is a big thing, and this is a big med as well. So if you're going to remember any of the meds, I would definitely recommend dobutamine and nitroprusside, just because again, those are the ones that are definitely different, things you haven't seen before, but those are genuinely the meds that we are giving for these issues, right? So worry about cyanide poisoning with that. Then again, to decrease, you have nitroglycerin. That's a potent like vasodilator. Hydralazine, ACE inhibitors, ARBs, and again, that's just having to talk about wanting like a vasodilator. So then we don't have to do if your blood vessels are so constricted, of course you're gonna have an increase of the workload of the heart after that. Just because they're not being able to pump out, just because all of that blood is so all of that blood pressure and the blood constriction that's going on, it's so small. So of course it's gonna be so hard having to like work, and the heart's gonna have to work so hard to get that blood to pump out to the rest of the body through those vessels, right? So if you give nitroglycerin, if you give these medications, they all help to essentially lower your blood pressure, but they do that by helping with a lot of that constriction and vasodilation there. So at least for these two meds, Dibutavine, nitroprusside, those are your go-tos. But I think the meds, she asked about contractility, and I think afterload, and you would just have to select all. And again, just think about what we're doing. What does afterload mean? Why would we want the vessels to be more dilated with this? And going on there. And then before we get into the whole intra-aortic balloon pump, I'm just gonna talk about preload really quickly. Again, so preload, if you see a P-Park pump, right? And then to decrease the preload, so basically you're gonna give diuretics, nitroglycerin, morphine, ACE inhibitors, and ARBs. Same exact thing as before. The only two ones that you're adding is diuretics and morphine. And so again, if we're helping to kind of dilate some of those blood vessels, we can help a little bit with the preload to decrease it. So if they're bigger, there's less kind of going through. And then to decrease basically preload, so how much is returning? Well, if you give diuretics, then it's able to leave a little bit more. And then morphine kind of follows more of the vasodilating effects, but the diuretics, it's just you're excreting go of all of that fluid, so then you have less preload, so less venous return back to the heart, because you have less volume overall. Does that make sense? So more of the nitroglycerin, morphine, ACEs, ARBs, those are more related to the fact that you're going to see more of those vasodilating effects. So they're not coming back and filling into that heart. But really, with the diuretics, it's just giving rid of your volume, so then you have less preload overall, is how I would think about it. So yeah, in terms of that, I would try to write it out multiple times and just see like if you get the meds. And then in terms of afterload, really with the intra-aortic balloon pump. Yeah, you do have to know this. She will ask you about this, but hopefully I can try to explain it in a way that makes sense. I don't know if the way that I'm explaining it is 100% right. I would like to assume it is, but the way that I think about it is a little bit of like a trick, I feel like. But honestly, it's not wrong. I just feel like I don't think about it in the same way that I think other people teach about it or think about it. I think about it in a way where I feel like I'm kind of cheating a little bit for some reason. I don't think I'm wrong. It's just for some reason I feel like people can overcomplicate this issue, and I kind of am just like looking at the images and I'm like, okay, this is how I think about it, and that's it. So that's how I'm going to teach you, because I feel like again, um, she's just going to ask you, it's inflating during diastole, it's deflating during systole, right? And then it's like, okay, what is it working? What is each side working to do when it's inflating and deflating, right? So I'm just gonna tell you how I think about it. But I'm pretty sure I'm pretty sure it's right, but I don't. I feel like my way is just different. So basically, intra-aortic balloon pump. It has a pump, and there's two sets of EKG leads, and so it's on its own monitor. So just know that, because that was just something that I think I got wrong. So it's on its own monitor, and it's triggered to deflate and inflate by the pump's EKG, right? So it's on its own monitor, so the pump's own EKG, because I didn't know that, and I was like, oh, that makes sense. Like I'm overcomplicating that, right? So it's on its own monitor. So when it's in systole, which again we're talking about the QRS, it's because the P wave is for atrial contraction, and then what we're talking about is the left ventricle. So kind of again dealing with that whole electrical conduction system in correlation to your EKG strip. And so then when it's in diastole, now you're having the T wave, right? So remember, it's PQRS. P, that's for the atrials, QRS, and then the T, those are talking about the ventricles. But you have atrial depolarization, ventricle depolarization, and then ventricle repolarization, right? So QRS talking about that ventricles contracting, T talking about those ventricles relaxing. So that's kind of what we're also talking about. It goes in accordance to what is going on with your EKG, or what the patient's heart conduction system, right? So it deflates according to that, but it has its own monitor going to that as well. And so you use helium to inflate the balloon, so also in case it ruptures. But really, it's indicated for any type of chest pain, and to decrease SVR. So again, this goes after according to afterload, because it's really helping out with a lot of the coronary artery perfusion. And then you're decreasing the SVR because again, we're talking about the workload of the heart. So if we're able to have a balloon, it's deflating and inflating. And you would think that in the inflating, it's affecting the way that the blood is going out. But if you're it's properly perfusing the heart, and then we're talking about when it's deflating, it also helps to allow some of that blood more easily to come through and allow for that to occur, right? And then the chest pain makes sense because again, that you're gonna have chest pain because you're not having a lot of that perfusion and oxygenation that's going to the heart itself and pumping out to the rest of the body. So this mechanism and this pump just helps to stabilize the workload of his heart right now, right? So I think with the confusing thing, it's like, well, why would we need like a balloon pump, and why does it like inflate? Because wouldn't inflating be like also cutting off some of that blood flow and everything? Well, your heart still needs blood itself, right? The whole point of cardiogenic shock is there's an aspect to it where your heart also is not being properly perfused through your coronary arteries, right? Because again, I think we sometimes forget, yes, the rest of the blood needs to be pumped with oxygenation, with blood, with all of those things. But your heart also needs to be properly perfused for that to occur in the first place, for you to be able to have proper perfusion and your blood be able to pump through it. But if your heart's not even properly oxygenated or perfused itself, it's not going to do that more effectively. So I don't know if that makes sense, but I feel like with the afterload, that's what you have to remember. Even though we're inflating it, it's also working on a lot of the perfusion of the heart itself. And when you're deflating it, it helps to get that blood out to the rest of the body. So I hope that makes sense a little bit when I'm talking about it. But let's get into actually what you have to know. You 100% have to know this because she asked us a lot of these questions. It was multiple choice, and you have to be reading it in terms of the verbiage again, because I think I remember I selected it and I got everything right on this question except for the fact that it said carotid arteries instead of coronary, and I was like, I did not read that it was carotid. And when I was reading it, I was like, why did I get that wrong? And then I was like, oh, that's and she was like, "Yep, that's not, the coronary arteries." And I was like, "Yep, I should have, known that." But I didn't read it. I was just kind of like, "Whoop, whoop," but and I was like, "Yes, I know this." But then so again, pay attention to the verbiage if it says it inflates during, like, systole, stuff like that. Because I do feel like that's where this part gets tricky, because it's just like, you know it sometimes, but when you're looking at the exam, you're like, "Oh, yeah, this is true," but then you forget, like, what's actually true. So, like, on the final, like, I would write it. When I saw that it was, like, a intra-aortic balloon, I was like, "Okay, let me write it before." So basically, when we're talking about this, so again, it consists of a balloon catheter. It's inserted into the aorta. It's a balloon. It inflates during diastole. So the thing about this too, again, if you're going to one of those people who just needs to kind of memorize it, um, D for deflates doesn't go with diastole. It's the opposite. It goes with systole. So the D goes with systole, and the I goes with the D. So I would just think about it like, unfortunately, it's going to be the opposite if you want to go that route. But really, it kind of makes sense. So inflates during diastole. Sorry, I spelled inflates wrong. So when the heart is relaxed. So with that, there's an increase in the aortic pressure, right? Because now you have all of that blood staying there, and we'll talk about that within a second. And then also you're gonna have an increase in the coronary blood flow. So with that, so this is the diastole. So when the heart is relaxing, it inflates. So again, it inflates. That starts with an I. So I'm gonna put that with the opposite. So it's gonna be diastole. Okay. And then when we're talking about how this works, this is how I think about it. I feel like sometimes when I'm talking about it, I don't know why, I just feel like I'm cheating a little bit because it's fairly simple when you look at it, right? So um basically, because it's inflated, well, now you have a buildup of that pressure, like here, right, within the aorta, because the blood is not being pumped through this whole entire thing because of the balloon that's inflated during it, right? So of course you're gonna have increase in the aortic pressure because this is already pressurized here, and then you're inflating it, so there's more pressure, right? Because um Yeah. So in terms of the coronary blood flow, I kind of think about it like, well, here's all of your vessels and stuff like that. So then the blood isn't necessarily going out over here, but more through here being able to perfuse your heart and work on that to work on your heart itself. So I feel like again the way that I think about it, I don't know if it's technically correct, but I feel like in my head it makes sense to just think about it this way because it's like okay, yeah, because there's a balloon, you're gonna have pressure here. Um, but because of the fact that it's inflated, well, you're gonna have more of the blood flow perfusion in the actual heart itself for that. So that's how I would think about it. I hope that makes a little bit of sense. But that's just how I think about it in terms of deflating. So again, it starts with a D. It's deflating. So it's not going to be during diastole. It's going to be during systole. So now you're having reduced pressure in the aorta because it's deflated. So again, going back to that, because of the fact that now it's less, so now you're having more of that. It's more open. There's less pressure. You see those effects there, and then with that, it also decreases afterload, right? Because it allows the left ventricle to pump blood more easily. And I would just think about it, well, like, yeah, now it's deflated, so now the blood's able to go out to the rest of the body. If it's inflated, it's not able to go out to the rest of the body yet. So that's literally how I would think about it. I don't know if that's gonna help. That's just how my brain works. And so the deflation also because there's more blood going out to the rest of the body, that's gonna help to increase your overall cardiac output. So this is what again talking about when the heart is contracting, and then also when the balloon is deflated, so that it can focus more on getting that blood flow out to the rest of the body and go out that route. Whereas when it's inflated, it's more about talking about helping the actual heart itself, not necessarily focusing on going to get blood out to the rest of the body. And you have obviously increased pressure there because there's a straight up balloon that's inflated. And then with the other one, you're not going to have as much pressure there because of that. So the right side or which is the deflation of the systole that helps to decrease afterload as a whole because now you're having less workload because it basically and again how I think about it less workload because there's more blood being able to get to the rest of the heart itself um, because it's deflated, right? So then it's we're able to get all that blood flow to go out and it's like wow, there it is. So that's kind of how I think about it. Again, it just feels kind of simple the way that I think about it. I'm just like okay, inflates because during diastole. And again, it also makes sense because you want to help to get that cardiac output when the heart is contracting because we're trying to contract and get that blood flow to go out, right? It makes sense to be inflating during diastole because the heart's already relaxed. It's not going to be pumping blood out because it's relaxed, right? So it's more of talking about okay, how do we help perfuse the heart itself whenever it is during diastole because the heart is already relaxing, right? If it's contracting, if the heart is contracting, we're going to want to pump that blood out and help the heart to pump that blood out to the rest of the body. So what is pumping that blood out to the rest of the body? What verb is that? What verbiage is that? What term is that? Well, that's afterload, right? Cardiac output. So I feel like that's how I think about it. It's more of talking about like, well, yeah, it makes sense why it would be inflating during diastole because the heart is already relaxed. And we are more wanting to perfuse the heart and yes, you're going to have an increase in aortic pressure because there's a balloon that's pumped. With deflating before systole, right? Well, yeah, we would want to help the blood be able to perfuse to the rest of the body when the heart is actually contracting, which is in systole, right? And so now you're having a reduced impression in the aorta because one, it's deflated, and then you're having a decrease in your afterload because now the workload of the heart is that it's deflated, it's helping to go out to the rest of the body. And then it also allows the left ventricle to pump blood more easily. So, again, talking about afterload. And then in turn, because you have more blood flow going to the rest of your body, you have an increase in cardiac output. So if you don't know the differences between cardiac output and afterload, well, remember afterload, the way that the workload of the heart having to pump blood out to the rest of the body, and in terms of cardiac output, that's just how much blood is within your circulatory system, going to the rest of the body, times your heart rate. So your stroke volume times your heart rate. So that's kind of how I think about that overall. So assessment, infection, dissection of the aorta, emboli, ischemia, kidney damage, and failure because it sits right above the renal arteries and below the arch sometimes. And then this is the one big thing about the assessment. She didn't even ask us about the other stuff. It's just knowing the actual what's going on with the intra-aortic balloon, how that works, and why the inflation and deflation is definitely important, and because they have different things and that they hit on. But basically, you check its for place and migration in terms of your assessment. So you want to make sure that it's in the right location, right? It's not moving anywhere, anything like that. So when you're checking for the right place and migration, you want to look at the left side radial pulse. So the left side radial pulse, and if something's going on, that's probably an indication the balloon pump migrated up. And then if you're looking in terms of the balloon pump migrating down, you're going to look at the urine output. So those are things to, again, make sure you're reading it, because it could say the balloon, you're looking for migration. The nurse is like assessing a patient's intra-aortic balloon for possible migration down or downward, right? And checking their left side radial pulse. Well, that's not right, because obviously you should be looking at the urine output. So it is a little bit tricky, but again, it makes sense. If it's migrating up, you're going to be looking at the radial pulse. If it's migrating down, you're going to be looking at that urine output, because again, it's sitting on top of those renal arteries and all of those things. So that's kind of the only other thing I had to just kind of know, like, okay, left side radial pulse, urine output makes sense if it's going down, makes sense if it's going up. Boom. Don't overcomplicate that right there. I feel like the only thing about that's hard about this for cardiogenic shock, know your crap, type it in, P-Park pump, dobutamine, that's for the contractility, nitropicide, that's for your afterload. You're worried about cyanide poisoning with that one. And then you also have the intra-aortic pump with that afterload. And then the preload P-Park pump, you're going to have the same things, but you're also adding diuretics, and you're also adding your morphine to that as well. And that's pretty much it. And then the rate, I feel like you guys can kind of figure that out, even if she were to ask you, because it's like, okay, atropine, that helps to increase it. If a patient is, super bradycardic, usually one of the first things they give is atropine, epinephrine, or like you can possibly use a pacemaker. Okay, so that's those things there for that. So now we're going to go into sepsis, just because there is a little bit there. But again, I'm not going to go over everything, just because I feel like you guys know this, because we talked about sepsis so much within these last 4 semesters. So again, what is sepsis? Well, that's a systemic infection. You guys know that. Mortality rate is huge. Obviously, bacteria is the biggest cause with an infection. Sepsis basically is a continuum. So what does that mean? So I do think you should know this and understand this anyway. So the continuum starts in an infection. Now you got SIRS, that's an inflammatory response, right? Because remember, the pathophysiology behind sepsis is now you're having like a systemic infection. So your body results to an infection through inflammation, right? So what's happening is now you're having systemic inflation response. And so then you're getting into sepsis. Sepsis meaning now you're not being properly perfused, oxygenated. You're having a lot of that, your metabolism having to have a higher demand. And so you're having a lot of hypertension. Because again, you're seeing all of those where the response of that inflammation, that platelet or clot coagulation stuff, and any terms of like respiratory symptoms, you're just not being properly perfused. You're having that third spacing, capillary permeability. So sepsis, you guys know that. Severe sepsis, okay, it's getting a lot worse. Now you're getting into septic shock, right? And then with septic shock, that's where it comes MODS, DIC, ARDS, all of those issues there as well, which also ties into septic shock. Patho. So again, remember we have an infection, we have different responses. So the vasodilation, increased permeability in the clotting process. So with that vasodilation, because of blood flow, you have maldistribution of blood flow, and then you also have myocardial depression. So that, again, is seen in the later stages. So that's why at first with an infection or with sepsis, a patient has an increased heart rate. And that also goes with like things like cardiogenic shock, just because your heart is trying to compensate to get proper perfusion, oxygenation to the rest of these organs. So that's why you see that. And then because of all the vasodilation that's happening with sepsis and the increased permeability, right? That's why it's important that we give fluid replacement in addition to help with everything that's going on, just because, again, you're having all of that permeability, capillary permeability be increased. So all of that fluid's able to get out of those vessels, and now you got nothing. And then you're just having a bunch of edema because you gave more fluid and you're not really helping to manage the actual vasodilation with that. So in terms of general variables, I feel like this is kind of obvious. I just straight up she told us to memorize this. She did not ask us this at all. So go with that what you will. I still would do it, and I feel like it's something super simple to kind of learn, or kind of just memorize and write down. So general variables, temperature below 96.8, 100, or above 100.9. That makes sense. That's our regular parameters, anyways. Heart rate above 90, respiratory rate above 20, um, WBCs below 4 or above 12. So you see those there. Um, for the SIRS, again, they're talking about inflammatory response. So you're not necessarily in the infectious state yet. And then you're having the basic ones: temperature, heart rate, respiratory rate, WBCs. Once you go to the national early warning score, that's something that we start being able to see if they're at risk of having organ failure, right? And also for septic shock. Well, now you're just adding more stuff onto it. You still have the respiratory rate, you still have the temperature, you don't have the WBCs, you have the heart rate, but in addition, you also want to look at their SpO2, their blood pressure, and then their level of consciousness. So again, that's just going deeper into if they're being properly perfused, oxygenated. And then with Muse, that's basically the same exact thing as News, but now you're also adding urine output and WBCs with that. So make it more specific again to what's happening to the other organs and also what's going on with your actual WBC. So it's funny because the first one and the second one also have WBCs, but then the middle one doesn't. So that's why what I did was is that I was like, you know what, I'm just going to think about it how I think about it, and I just wrote it down to the side, and that's what it is. But I do think she actually does want you to know the SOFA one for sure. So we'll talk about that right now, but at least for the other ones, I memorized them, but I don't think she actually wants you to know that. I think the only one she does want you to know is the sequential organ failure assessment. So that one is altered mental status, and you need to know GCS below 15 or below their baseline. So patient coming in with an infection, well, if it's not terrible yet, they really should still be alert and oriented, right? They still should have a GCS of 15. Even though I feel terrible whenever I'm sick, I don't feel like I don't feel great, but I'm not altered. I can still tell you what year it is. I can still move my eyes. I can still have a proper motor response. It's just it's not fun, like picking up my extremities, moving around. And then my blood pressure usually is a lot, I think, lower, but it's not too low, right? And my respiratory rate is higher, but I shouldn't be in like respiratory distress. So basically with the SOFA assessment, you do need to know this. She will ask you this. So GCS below 15 or below their baseline. So let's say they came in with like a 12. If they now are at a 10, well, that's below their baseline. And if they normally are around 12, right, they have just things that they can't do, like they don't move, um, they have musculoskeletal issues, things like that. It's okay, but as long as it's not below their baseline, because she will ask that, has to be below their baseline or below 15 if that should be everybody's usual. And then systolic blood pressure below or equal to, so just remember it's below or equal to 100, and then respiratory rate above or equal to 22, and she will ask you the above or below, like it has to be that. And then to be positive for this, they have to have 2 out of the 3. So there's only 3 of them, but it's 2 of the 3. So if I am, let's say my natural baseline should be GCS of 15, but if I was at like 12, right? And then my systolic blood pressure was like 50. That's low, first off. But if I had those 2 things, well, guess what? I am positive for that. So you do need to know that for sure. In terms of inflammatory variables, that's just some more things you guys should already know with that. So CRP, inflammatory enzymes, procalcitonin, obviously a big indicator of sepsis. WBCs, we know that, and then glucose, stress response of what's going on. And then in terms of the acute organ dysfunction stuff with this thing, guys, just remember this is like any labs that you guys have touched before. Don't overthink it, right? So if I'm talking about like respiratory and level of consciousness, well, yeah, like hyperglycemia, it also has to deal with a lot of pancreatic issues. But again, AMS, hypotension, hypoxia, kidneys. Well, you're going to be looking at the urine output. You're going to be looking at their creatinine, your liver, coagulation, INR, thrombocytopenia, hyperbilirubinemia with your coagulation factors there, GI, paralytic ileus, are they having diarrhea? What's going on? Tissue perfusion as a whole, lactate, and then mottling, which is basically just discoloration of the skin, poor circulation there. all of this stuff, you guys already know. Like, don't, and she doesn't need you to know this, and even if she did, you would be able to point it out because you're like, "Oh, yeah, of course I would look at the urine output for their kidneys." But, it's more of just knowing that SOFA assessment there. And then in terms of the rest of this stuff, it's actually pretty self-explanatory, but I'll still go over it. So septic shock. So it should be severe septic shock. For some reason on the document, I just had like severe sepsis, I think. But basically, what is the difference between like sepsis and like septic shock? Well, the difference is that the hypotension cannot be reversed with fluid resuscitation. So at this point, there is a problem with tissue perfusion, and there is definitely organ dysfunction. And then obviously with sepsis, we have a blood pressure problem, but there isn't necessarily organ dysfunction yet. Septic shock, now we're getting into that organ function, plus the hypotension of what's going on. You can keep giving fluids, it's not working. So that's where the issue gets into this. So causes every same thing that we talked about before in terms of infections, gram-negative bacteria, gram-positive bacteria, pneumonia, things like that, just infections, right? So manifestation with stages, I feel like you guys already know this, early versus late. It's the same exact thing that we learned in third with sepsis. Warm, cold, because at nighttime it gets cold. So tachycardia with the early, BP normal to low. You have a wide pulse pressure, skin warm and flushed, and there's confusion already kind of in the early. But with late, you're still having tachycardia because your heart is wanting to compensate. You're having hypotension for sure because the blood pressure just can't maintain itself anymore. Narrow pulse pressure, skin cool and pale, so your body's kind of trying to give up. Decrease level of consciousness, anuria, hypothermia. Anuria being below 100 mLs in the 24 hours, so even more hypoperfusion of what's going on with the late because it's late. So, hemodynamic parameters. You 100% have to know this. The only thing you have to know is in early. Everything is high. Everything is high. Only cardiac output and cardiac index. Remember, also cardiac index talking about body surface area in correlation to cardiac output. And then the only other thing you have to memorize is above or increased SVO2. Those are the only thing you have to know. Everything else is low. I don't care if it's early. I don't care if it's late. All you have to know is in early, everything's below except for cardiac output and for SVO2. And so the way that I would think about this, if you need to know like the why, like me, I can't just memorize things. I have to unfortunately always ask, like, well, why is that? So with afterload, basically, again, what the heart has to do to overcome it, to pump blood out to the rest of the body. So that's why with decreased SVR, well, it's coming to work super hard, but it's already decreased because you're having a lot of that perfusion problems and everything there. The same thing with late. With CVP, PCWP, that has to do with a lot of your fluid status and what's going on there. Well, you're already having hypotension, so both of those are going to be issues there. But in terms of why CO and CVO2 is high, well, high CO, basically because, again, remember it's stroke volume times heart rate. Well, a lot of your heart rate is trying to compensate for that. So in early sepsis, this is basically a compensation response to all the vasodilation going on and to the decreased vascular resistance going on, right? So the normal value for that was 4 to 8 for cardiac output, and then remember it was half of that for cardiac index, so 2.5 to 4. So basically with that, yeah, your heart's just trying to increase that heart rate to kind of help with that compensation method. And the decreased SVR, that's just because you're already vasodilating in a lot of. So if you have so much vasodilation, right? Why does your heart your heart wouldn't have to work that hard to get blood out to the rest of the body because your vessels are already like vasodilated, right? So you're not going to have to work as hard. But with the cardiac output, it's still going to be high technically because your heart rate is really a lot of that compensation response to all of the vasodilation going on. And it's just trying to have as much cardiac output as it can to help with all of this stuff. CVP and PCWP all has to deal with what is going on with your actual fluid volume. So of course you're still having hypotension, so that's why you're seeing all of those things there in terms of the fluid status with that. But same thing with vasodilation. Again, you're having those issues there, and with your capillary permeability. In terms of SVO2 being increased, at least for early, well, basically SVO2 measures the percentage of oxygen in the blood, right? Returning to the right side of the heart via the pulmonary artery. So percentage of oxygen in the blood, right? So thinking about that, it technically, I can understand how people get this a little bit confused, but it reflects how much oxygen was not used by the tissues, right? So in early sepsis, so this is talking about like the oxyhemoglobin curve a little bit. Cells often struggle to get the oxygenation, and now you have a lot of impaired cellular metabolism, but this leaves a lot of more oxygen in the blood itself. So that's why you end up having an SVO2 because the cells can't use or actually bind to the O2, right? So it's just left in the blood. So this is kind of talking about like when that hemoglobin oxygen, I would kind of think about it, it's correlated to this a lot, right? So again, the cells can't pick up the oxygen, so they're just left there. So that's why you see a lot of the SVO2. So you still have respiratory issues, absolutely. It's just more of the fact like this is just like a response, or not a response, but this is just an after effect of what kind of is happening through the pathophysiology. So again, those cells can't pick up the oxygen, they can't bind to that oxygen. So thus, because you have the oxygen remaining in the blood, it's just staying there. So you're not being properly oxygenated. It's just more of about the fact those cells aren't picking it up. They're just having to stay there. So of course, like if you're looking at your SVO2, you do have a lot of it remaining in there, and that's why you have a high SVO2 because it's not a good thing. It's just more about the fact that it's not like, oh, my body's being more properly oxygenated because that's not what's happening, right? We're already in sepsis. It's just more about the fact that your cells can't pick them up, so that's what's left over. So that's why it's still high. So in terms of late, now the problem is we're already so late that with the cardiac output, it's already too late. Like there's nothing you can do to increase the heart rate, do anything there. The heart is still going to try, so that's why you're still going to see an increased heart rate. But in terms of like what's going on, heart rate times stroke volume, yeah, no, it's not, your heart's not being able to pump directly or effectively anymore. So overall, less cardiac output. And remember, this is late, so this is like your body's basically like about to give up, if not giving up. In terms of decreased SVO2, at this point, yeah, there's just decreased gas exchange as a whole. So in later sepsis, obviously as CO drops, basically you have less tissue perfusion, less oxygenation there, and so then there's just less oxygen delivered to the tissues as a whole. So eventually, like even though yes, at the beginning there was just the cells just weren't binding. Well, at this point, you're not even breathing anymore. You're kind of just having a lot of issues with perfusion, oxygenation. So if that's the case, there's just less O2 overall now. So because there's less O2, you're having less CVO2 there. Since what it is, it's just the percentage of oxygen that's in the blood. That's returning to that specific right side of the heart. But what I would just, if you don't really understand that, I would just again think about it. Well, it's just that this SVO2 cardiac output, those are just kind of like, at least for the cardiac output, that's more of a compensation thing. Whereas with the SVO2, that's just unfortunately your cells can't pick it up. It's just high because they can't pick it up. And then for the later half, it's just like, well, everything's below because there's so much hypotension. Your body's kind of trying to give up. It's still it's giving up overall. It can maybe compensate with some stuff, but at the end, it's too late, right? So less overall. So that's why you see those being all down. So yeah, that's what I would think about for that. But if anything, if all you have to know is, and this is what I put to the side, early, increase cardiac output and increase SVO2. That is it, point blank, period. And then the rest is down. So early, increase cardiac output, cardiac index, increase SVO2. She will ask you this for sure. That's all you have to know. Okay, so I'm not going to go over the bundles because you guys should know that already. So again, read that 1 to 3, 6 hours, lactate, blood pressure, blood cultures before antibiotics, and then administering those 6 hours, vasopressors. You can read that more. And then basically fluid resuscitation. Okay. It can either be NS or LR. I think Harding had told us it was LR, but Mandiola would argue, I think she was like, she kind of explained it to us because basically there's not enough studies to, I think, show that LR is as beneficial as NS, because I think Harding was saying that the whole point is that LR can be changed into bicarb, but Mandiola's response to that was like, wait, but we don't even know sometimes when these patients are coming in what their liver function actually is, right? And because of all of the issues with sepsis, your liver function is not going to be working anyways. So there's not really a point sometimes of giving LR. And then she argued that there wasn't that much studies to prove that. So at least for Mandiola's class-wise, you will be giving NS for sepsis, right? And I kind of understand her way of thinking too, just because again, yeah, you're not really sure. Both are good, and they both are crystalloids, isotonic fluids. But again, you're just going to be giving NS, I guess, for your first fluid resuscitation when it comes to Mandiola's class. Okay, so just know that. Again, colloids and blood isn't recommended first, but later, because that's more of like having to do with your overall volume, what's going on, and we can try to help out. But that's again later responses because again, you're still having some, vasodilating effects, but and late, it's like already too late, right? So there's that with NS, and then vasopressors. So again, vasopressors, if we just give fluids, that's great, but that doesn't actually help with the hypotension that's going on. So how are we supposed to get those fluids to go out? Because the problem is that again, with the increased capillary permeability, you can give all these fluids, but they're just going to leak out of the vessels. Now you get more edema. So you need to give some vasopressors so you can help with that blood pressure being able to get those fluids to the rest of these organs. So you do need to know this in ICU. Especially when you start clinic or orientations there and rotations. I was like, what's that word? Yeah, rotations there. So you want to make sure you're giving vasopressors in this exact order. So your MAP goal is above 65. You absolutely need to know that from here going on forward. Your MAP goal is always going to be above 65. So above 65, it's at 60. Well, guess what? To give them more, you have to titrate and do all these things. So you add them in order and then you take them off in reverse order. So that makes sense, right? If we're going from least to the best one to the least one, and the patients, okay, I would think about it like this. For those of you who've been in ICU, if my patient has been on all four of them, and let's say they're maxed out already and they're about to max out on the phenylepinephrine, which is the last one, at that point, none of their organs are working. That's when people start considering like comfort care for sure. Because at that point, like that means like if we were to take this off, like there's no way. Right. So that's one of the things that I think you'll start seeing in clinic. If you know that if you go into the room and you see that they're on like majority of all four, that's not a good thing. If you see that they're only on like one, I mean, it depends. Like, are they maxed out on it? Are they going to move to the other one? So that's not a good indication, right? That means we need more vasopressors to help maintain your perfusion state. So yeah, you add them, you take them off in reverse order. You need to know that MAP goal above 65. So you're going to start off with norepinephrine, vasopressin. And so the reason why it's not necessarily a vasoactive drug, but it's like synthetic ADH, so it helps with your overall fluid volume. And then epinephrine, and then phenylephrine. So that's what I would say. NVEP is your order. And then you're going to take it off in the same order. So if I'm on norepinephrine and then they titrate it, meaning titrating it to keep my MAP goal above 65. So you give me norepinephrine, and then you're going to give it to me, and then my MAP is still at 60. You go full max on that according to what it is. Different hospitals have different numbers, I think, sometimes, but usually it's the same. But you don't need to know that, so I'm not going to say it. And then vasopressin, okay, you add that one on. You max me out on that one. So now I'm going to epinephrine. Okay, well, now my MAP goal is like 70, 80. Oh, now it's like super high. Okay, well, I don't think we need the epinephrine anymore. So let's titrate that down. Oh, she's still having a good MAP. Okay, let's just take it off completely. Oh, vasopressin. Okay, well, her MAP goal is still like 70, 80. Okay, let's take it off a little bit. Let's titrate it back down. Okay, her MAP goal is still about 65. Norepinephrine. Okay, we're still maxed on this. She's like 66 right now. Okay, we're gonna probably keep it there. Oh no, like her MAP goal is going a little bit higher, so let's just titrate it down. So that do you see that? Like we're basically helping out with that. If they're maxed out on a lot, if they're giving them more, that's a bad thing. And then you can go down in that reverse order. That's a good thing. So if I'm like 65 and I'm on like the last setting of like norepinephrine, if I'm like above that, that's a really good thing. So again, memorize that. Do what you got to do for that. Inotropic therapy, again, contractility, we're getting dobutamine, especially if the patient has that heart failure, MI, any cardiogenic issues of contractility. So that can help out with that as well, with that cardiac output for sure. And then in terms of other medications, steroids, she kind of said that this was still questionable. It's not necessarily recommended in sepsis because of some of the issues that happen, like hyperglycemia, adrenal insufficiency, your susceptibility to infection. But it's given because it's more about the fact was when they're in a shock state, like septic shock, basically they're not able to maintain their blood pressure, and you can give steroids more because like of the cortisol, and that's helped to maintain blood pressure there. So that's kind of more like a fun fact. Like we don't give steroids because it helps out with like inflammation or anything like that necessarily, because again we're already late to sepsis. But it's more of indicated because they're not able to maintain their blood pressure, and you need cortisol to be able to maintain your blood pressure. When we're talking about patho and anatomy and physiology. So That's why sometimes they give steroids. And then for glycemic control, basically above or equal to 180, because again, their blood sugar is probably going to be high. So you're going to start them on insulin, finger sticks hourly, and then obviously you can switch it with the provider notices that they don't need to be on, IV insulin. You can switch to sub-Q, um, and then the frequency of those finger sticks can change to 3 to 4 hours with that. So yeah, with that, you just need to know the hemodynamic patterns, the SOFA. You should know the continuum of the like SIRS to sepsis. I don't know if she asked that, but I feel like you do need to know that. Bundle. Remember what the if it says 1 hour versus 6 hours, because a lot of us didn't read that too, so we got it wrong. And then after that, vasopressors in that order, and that's it. So vasopressors, NS, the bundle always, hemodynamic parameters. But what did I say? All you have to know for early is that it's going to have increased what? CO, SVO2, and then the SOFA, 2 to 3 of them, GCS below 15 or below their baseline, blood pressure below or equal to, systolic blood pressure below or equal to 100, respiratory rate above or equal to 22. And I do think she had us type this in. And it has to be exactly how it is right now. You can't just say GCS below 15. You have to say GCS below 15 or a below their baseline. You can't say blood pressure. It has to be systolic. So just remember that. Um, and then the last thing that we're going to go over is acute renal failure. There's quite a bit of this. I'm not going to go through everything because I don't think you have to know it. But basically, acute renal failure, I have a little bit of some, I think, not issues, but I think some of this stuff, I remember in like the PowerPoint, it was different than what she had said. So I'm gonna try to say what she said, but that could be different from what you guys learned. But it's like for some of this stuff, I remember I was like, huh, but I thought on the slides it said ACE inhibitors and NSAIDs were pre-renal, but it's like no. I knew that I wanted to say intrarenal, but I was like, oh, but on the slide she said this. So we had to get a lot of like clarification about that stuff. But I'm pretty sure that this is the right information just because like I had to alter that because I think she just maybe forgot to update the PowerPoint. But it's fine. So, with sudden decline in GFR, which leads to retention of nitrogenous waste products, so that's where we get the term azotemia because that's a buildup of BUN in the blood. So yeah, you're having decline in your renal function. So usually accompanied by oliguria or anuria, right below. For the anuria is below 124 hours. You have high output renal failure, so it's putting out fluid but it's not filtering. So that's when also you see that the fluids maybe might be almost clear. So in terms of the etiology and patho for the causes, really this is what she will ask you this for sure. Pre-renal. I think about it anything before the kidneys, intrarenal, anything that's causing direct damage to the kidneys, and post-renal, anything that's obstructing the urine flow after. So intra meaning in, pre, before, post, after, right? So pre-renal, I would just think about it anything that's having to do with any type of volume issue and any reduced blood flow to the actual kidney. So if I'm having a patient who has like sepsis, well, it makes sense this would be more of a pre-renal issue because you're not having vasodilation, you're having major vasodilation, so none of that volume um, or blood flow is being able to go, and you're not being properly perfused. So, but that's a pre-renal issue. That's having to just do with the vessel. That's have nothing to do with the actual kidney itself. Unfortunately, it's just because we aren't perfusing. Now your kidney's damaged. So that's where you see volume depletion, impaired cardiac performance, right? Because if you're having stuff like cardiogenic shock, heart failure, again, you're not perfusing good, and so that's where you see that renal vasoconstriction. So that blood flow is not being able to get there as well. So those are all volume vasculature issues, right? In terms of intrarenal, so ATN, which is basically tubular necrosis, has tubular in it, right? That's a physical in the kidney issue. Thrombus in the kidney, stenosis in the kidneys, malignant hypertension, glomerulonephritis, diabetic neuropathy, sclerosis, SLE, toxic damage. Do you notice that those are directly damaging the kidneys itself? So SLE, remember that that's lupus, but that has a direct impact on the kidneys itself. So on the kidneys itself, right? Not a pre-renal issue. It causes issues to the kidneys itself. And then your medications with ACEs and NSAIDs, you have kidney issues with those. Those are going to be affecting the kidney directly. So that's why they're there. And it makes sense. But I remember the slide she had it on pre-renal, but it should be intrarenal for that. In terms of post-renal, I would just think about any type of obstruction. So calculi, kidney stones, right? Urethral strictures, prostatic diseases like BPH, then you're having all of that um, pressure, especially like when we're talking about like the prostate, right? Talking about anatomy wise, it's not going to be able to allow that urine to go and empty because of all of the pressure, what's going on within your ureters and everything. So now it's just backing up into the bladder. Then it's going to back up to your kidneys and everything. So with tumors, Foley catheter obstructions, trauma, spinal cord, nerve damage, because now you can't really um, urinate correctly, void correctly. So if that's the case, those are all obstructions, right? So I would just think about it pre-renal, that's any volume issue, intra-renal, that's directly affecting the kidneys, post-renal obstructions is basically how I would think about that. Don't overcomplicate it. I literally didn't even memorize everything that was on here. I would just think, does this affect the kidneys in like directly? Yeah, it's a medication, or because of this, it's pre-renal because of the volume stuff, it's post-renal because it's an obstruction. So and also the location of where it's at, right? So acute tubular necrosis is what we're talking about for the intrarenal. So basically, it's characterized as death of the tubular cells in the kidneys. And so there are two main processes for this: ischemic or nephrotoxic injuries. So ischemic meaning again the lack of the blood flow, kind of like think about a stroke, right? Ischemic, we're having a clot there or something, and then it has lack of that blood flow to there. So that's why we end up seeing those signs with the stroke for ischemic. Same exact thing for ischemic injuries, there's just lack of blood flow going to that site. Nephrotoxic injuries, that's just a certain substance that's physically harming the kidneys itself. And then causes of ischemic, it makes sense. We're having decreased blood flow with sepsis, severe hypotension, dehydration, not enough blood volume anyways, heart failure because of the BP effects, surgeries because again of the BP effects with anesthesia, and in general fluid shifting and volume shifting of what's going on as a result to all of the inflammation and trauma damage with that. Causes of nephrotoxic injuries, medications, because those are directly affecting the kidneys itself as well. So aminoglycosides are a big one. So that's another one that obviously like we can talk about when we're talking about intrarenal. Um, and then damage and death of renal tubulars in terms of the contrast-induced ATN, in which we'll talk about that through the administration of contrast. So yeah, so nephrotoxic injuries, you can look at least for aminoglycosides, like your BUN, creatinine, peak, and troughs. But when we're talking about like contrast, we know that we're using that for a lot of our CTs, MRIs, anything like that. So whenever we're talking about contrast, we need to make sure we're monitoring the kidneys, the patient's kidney function. So we talked about this like all 3 semesters. So now it's like finally, what do we do in case something happens where we're having a nephrotoxic injury, so ATN, but that's caused because of contrast. So basically, the use of contrast that ends up, like I said earlier, leading to damage on the tubular cells. And so, after what you're going to give is acetylcysteine that's used to help prevent contrast induced nephropathy. And then you give it basically 2 days, 2 doses the day before and 2 doses after you do the contrast. And I believe that there's an 8 hour thing that's on that as well. You want to do it like 8 hours before, 8 hours after, but as long as they get the 2 doses the day before, 2 doses the day after. So I would just think about it like that. Um, but really, you just have to know it's acetylcysteine, right? And then that helps to basically neutralize the O2 derived free radicals. I didn't really have to go too deep into that, but basically, there's a lot of damage that happens to the tubular cells, and you have a lot of oxygen free radicals that ends up damaging them specifically. So, if we neutralize them with acetylcysteine, it helps to prevent that damage with that. So, yeah, so if you just see contrast induced ATN, you're going to give acetylcysteine for that 8 hours, um, before, and then you also want to give 2 doses a day before, day after. In terms of pre-procedure and medications, also another thing is like metformin. That basically, that's why we look at that. We always say those things like again in the last 3 semesters, metformin we check because this can increase the risk of lactic acidosis, right? And then especially when that's one thing. And then when we're talking about a person with acute kidney injury or if the patient is dehydrated, we have a lot of those kidney effects and we damage the kidneys with that, right? So we look at their creatinine and BUN levels. And then again, for discharge teaching, we always want to talk about the weights, fluids, BP monitoring, And then again, you notify if there's 2 libs that you have gained in the last 24 hours, or if there's 5 libs within 1 week. So again, talking about this, all you have to know with this first part of acute renal failure, pre-renal, intrarenal, post-renal, contrast-induced ATN, acetylcysteine for that, you're going to give those doses there, the 8 hours. Before, after, and then metformin, obviously, it's another thing we look out for. Hey, patient, what should we educate you on? Well, obviously, what are your levels of BUN and creatinine, discharge teaching, well, fluctuations within their weights, fluid monitoring, and then obviously notifying, hey, I gained 2 pounds within 24 hours, and then I have had more than 5 pound um, a gain within 1 week. So, back to talking more about acute renal failure and getting out of that contrast-induced ATN, and the ATN tubular necrosis, all of that stuff. We're talking about manifestations. So I think I'm not going to go over this, but I feel like if you just read through it, you guys know this stuff already. It's renal failure things, you have a buildup of all of these things, because again, you're not excreting everything. So that includes also seeing manifestations of your electrolytes, like with potassium, things like that. So in terms of integumentary, I thought the one that was interesting was uremic frost, and that's just because of your uremia levels rising. But really, the rest of the stuff I feel like you guys know: anuria, lethargy, tachycardia, hypotension, or hypertension, depending on their um, history of what's going on with their kidneys, shortness of breath, cough, nausea, cool, clammy skin, anorexia, all of those different things there. With phases of ARP, I don't think you have to know this, but I at least would look through this really quick. So initiation, onset several hours, start to see urine output change. Maintenance 8 to 14 days now. There's a lot of renal damage. You look at your GFR, urine output is now the lowest, and then recovery. This is after you have that repair. So now you should be having more of that diuresis and maintenance of that. What's going on? Farm management, you guys already should sort of know this stuff, right? Because your kidneys are in charge of like with your vitamin D activation when it comes to your red blood cells, so epoprotein alpha with the production of EPO. So you guys kind of know some of their functions, and then again with things like phosphate binders, diuretics to get rid of all of the potassium buildup. You guys know, furosemide, spironolactone to keep the potassium if they need it. And then acetylcysteine, maybe again if they're having that contrast-induced nephrotoxicity. So you guys know that. I feel like that's pretty simple. Renal replacement therapy, what we've talked about before, I literally copied and pasted from before. So hemodialysis, separated from the dialysis, semi-permeable membrane, continuous ambulatory peritoneal dialysis. Oh, that's such a long name. Basically, that's through the peritoneal space, and so again, through a catheter, major complication, peritonitis. You can read that really quickly. I don't think she even asked about it. I do think the one thing she asked about is CRT. So continuous renal replacement therapy. That's continuous hemodialysis. So it also is known as PERT, which is percutaneous intermittent replacement therapy. And so the reason why they changed the name, this is something that she discussed, and I think she even asked us a question, is because it's only 23 hours a day, right? It used to be like where it was like 24 hours a day, or not 24 hours a day, but 23 hours a day. But they were like, why is it continuous then? It should just be called intermittent because of that 1 hour. So that's why the name changed to intermittent percutaneous replacement therapy. But they are essentially the same exact thing. They are the same exact thing. It's just they wanted to change the name because of that. So basically, within this, the system filters out excess fluid, but also helps to remove waste products and other substances dissolved in the blood. So it's basically the same exact indications as hemodialysis, but it's more used for people who are hemodynamically unstable. So if you're seeing a patient who has hemodynamic instability, you will be giving it. They will probably be placed on CRRT or PERT. So the reason why for that too is because it's slower, right? And so there's a lot more better outcomes for renal failure patients because they can handle a little more of that if it's a little bit slower. Whereas with the other ones, it's a little bit more faster, it's just kind of you're doing it. There's a lot more complications, but this, it's kind of like intermittently, 23 hours a day. So you're slowly doing a bunch throughout the entire day, right? So if they're hemodynamically unstable with like their CVP, all of those like cardiac output stuff, then it probably would be an indication to put them on PERT just because they might not be able to handle like hemodialysis like 2 or 3 days a week. Because once you're doing that, you're dropping like their cardiac output CVP all the way down. Because it's already low. So maybe doing a little bit throughout 23 hours a day would be better. So complications include obviously accessing and assessing for any time kinds of clots with that. So that's where we see, at least with the CERT, with the PERT and the CRT, same thing, just different name. And then again, having to deal with the main thing about this is hemodynamic. You're gonna put them on this, or they should be getting this, because that's what she hits on. In terms of nursing interventions, dialysis, nephrologist, and then their provider. So obviously they'll be doing that. Labs know that already. BUN, creatinine in terms of electrolyte replacements, hyponatremia, hyperkalemia. So some patients can get even higher. But again, what is their normal and if they're symptomatic, right? So if a patient is sitting at like 5.5, definitely not necessarily a good thing. But at the same time, if that's normal for them, they're sitting really high. If they're just sitting there like chilling, nothing's going on. I mean, still, you probably will want to contact your provider to see if there's anything that they want to do. But at the same time, if they're not necessarily symptomatic, it could be the case where the provider's like, they're fine, but let me know if it gets higher, you know? So at least for the treatments of hyperkalemia, again, we could always manage diet and nutrition. That's a big thing with renal function as we talk about, but really you're going to end up having to learn about some of the treatments of hyperkalemia, and you should probably know this anyways because there's a lot of different conditions where a patient could have hyperkalemia. So what we're going to talk about is just the treatments of indirect versus direct, and I'm going to try to make it as simple as possible. For indirect, I actually mixed them up on here for some reason, even though I like on the exam I already knew what they were. For some reason, I just didn't put the names here correctly. But indirect meaning you're taking it somewhere else in the body or outside of that, and then direct meaning it's straight up directly out of the body. You're hitting it exactly where it's supposed to be hit at. So with indirect, I'm not directly taking out um, potassium with these interventions. So there's glucose and regular insulin. So again, when we're talking about like the potassium shift and all of those within the cells, you can give insulin, right? And then you know that the potassium is going to go into those cells. But then the problem is if you give insulin, you would also have to give glucose with that because obviously if you're giving insulin, all of those sugars are going to go into the cell. So it's a great thing that they're going into the cells and the potassium will follow that. But then as a result, obviously, if you're giving someone insulin, all of that glucose is gone out of their blood. So now they're becoming hypoglycemic. So if some people with they're having hyperkalemia, we can give insulin per provider's orders, but you would also have to give the glucose with that and do glucose checks. But that's indirect, right? It's like we're indirectly removing potassium. It's not like I'm actually taking out potassium itself. It's just it so happens if I give insulin that the potassium is able to follow that. But again, you would have to give glucose with that insulin. For bicarb, again, this has to do with potassium being an acid and kind of being in that acidotic state. So with the bicarb, if you look at the equation of bicarb, obviously it has the HCO3. Basically, this can help make them alkalotic. We know that because it's a base, but it brings hydrogen out of the cell and it brings potassium into the cell because of that acid state and wanting to help alter those pH levels, what's going on within your blood. But again, directly it does take, or indirectly, it takes out that potassium just because it so happens to do that. So usually we see more of the insulin, but people I have seen like in one case, like really they did do the bicarb as well. So insulin, glucose, bicarb, those are indirectly, right? So it's just knowing that if you have to memorize it, you have to. But again, if you think about it, it's not directly taking out potassium. It's just it so happens the after effects was that. In terms of directly out of the body, right? So direct hitting that potassium, just taking that potassium out. It's just that the indirect again, those are just happens. The hypokalemia happens to be an effect of those giving those medications. With direct, that includes dialysis, which makes 100% sense because it's like you're just dialysis is just you're taking it out. You're taking out the potassium. Sodium polystyrene, which is K-exolate. It also starts with a K, but basically you're pooping out K. So you know how like with spironolactone, you help to keep that potassium in. Well, K-exolate is basically the opposite of that, but you're pooping it out and you're specifically hitting potassium to poop it, to get it out. So direct K-exolate, you have to know that it's sodium polystyrene though, and then dialysis for that. I had it there for calcium gluconate. It's not either of them. So if you see this as an option, it's not either of them. If you see as treatments what we can do for hyperkalemia, you can see all of these as an issue. But if she's asking you for indirect, it's just going to be the insulin and glucose and bicarb. If she's asking for direct, it's just dialysis and um, KX-Lite. So each of them should have two. Excuse me. So then in terms of calcium gluconate, that one doesn't go under either of them. What it does is it doesn't affect your potassium levels overall. The reason why you're just giving this is because it can increase your threshold for ectopic beats and buys you time. So it is not a treatment of hyperkalemia at all, in terms of actually affecting your potassium level. So if like the question was like a patient comes in with hyperkalemia, the nurse wants to give them calcium gluconate, but like what is the reason for that? The answer is not to lower your potassium level at all. What it is just buys you time, increases their threshold for ectopic beats, because obviously when you're seeing hyperkalemia, you're seeing a lot of the cardiac dysrhythmia changes, ectopic beats of what's going on. So calcium gluconate can help increase the threshold of that. It's kind of like again when we're talking about like seizure thresholds. You want to make that a little bit higher for some patients so then they're not at risk of having seizures all the time. So calcium gluconate increasing the threshold for that because again we're hyperkalemic. So no, it does not affect your potassium level. So that's why it doesn't go underneath direct or indirect because it doesn't take the potassium out. It just helps in case you have hyperkalemia. So for this, all you have to know, pre-volume stuff, intrarenal, things that are damage to the kidneys itself, and then post-renal, things that are obstructing, ATN. There's two different types, ischemic, which is blood flow stuff. So that would be more like your pre-renal stuff. And then the nephrotoxic injury, that would be more of like the medications inside the renal issues. So that also includes contrast-induced ATN. So that obviously you're going to give acetylcysteine. And then I'm trying to think of what else. Discharge teaching, CRT, percutaneous intermittent replacement therapy. That's the same thing. Just no, it's changed name because it's 23 hours a day, not 24. You give it hemodynamic, it's slower. And then treatments, indirect versus direct, calcium gluconate, not either of them, doesn't affect your potassium level, but it buys you some time for the threshold of ectopic beats and dysrhythmia stuff that's going on with cardiac symptoms and issues there. So other than that, okay, so if you reach this point of the video, I'm so sorry, it probably was super long. But what I'm gonna tell you, this is gonna be, I'm gonna try to do it within like 4 minutes, is a sum of what you have to know and what the probably she's gonna hit on. Okay, I said at the beginning, EKG strips, ABG, vent settings always. So all of those things always you should know. Pulmonary embolism, most common cause DVT, lower extremity. So if you're seeing that, they're definitely at risk for that. Risks always includes the things as before. Vercose triad, 100% you have to know this. Stasis, hypercoagulability, vessel wall injury, manifestations, sudden pleuritic chest pain, shortness of breath, hypoxemia. Pulmonary angiograph is the golden standard, and then you see those surgeries and everything there. So that's done with that one. In terms of sepsis, I'm just going down that each of my study guides. SOPA assessments, 2 out of the 3 of them, the GCS below 15 or below their baseline, systolic blood pressure below or equal to 100, and then respiratory rate above or equal to 22. You might need to know this chart, but don't freak out if you don't really have time. You want to focus on other stuff. I just did it anyways. Severe septic shock. The difference between sepsis and septic shock is now you're having organ dysfunction as well as your hypotension cannot be reversed with fluid resuscitation. Early and late stages, the same things of what we learned before. Warm, cold, both of them have high heart rates, but you're going to see the differences between late being decreased perfusion states, so you're going to have all of those other symptoms. Hemodynamic patterns, the only thing you have to know early is going to have the increased cardiac output and CI versus late, that's going to be low, everything's going to be low. And then again, in early, increase SVO2. So all you have to know, increase SVO and, increase CO and then increase SVO2. And that all of the rest of it's going to be below. 1 to 3 hour bundle, 6 hour bundles, you're adding the vasopressors, you're remeasuring the lactate if they need it. And then that's pretty much it. And then fluid resuscitation, you choose NS, vasopressors, the order is as it goes, you take them off in reverse order. Norepinephrine, vasopressin, epinephrine, and then phenylephrine. So MAP goal above 65, you titrate them, and then basically you go from there. But it's so funny because every single time I'm recording, it's like my iPad just dies. In terms of renal failure, pre-renal, anything having to do with volume really issues before, intrarenal hitting it directly in the kidney, so the ATN, the medications, post-renal, calculi, obstructions, anything there. ATN, having to talk about contrast-induced ATN, the use of contrast. Basically, you can give acetylcysteine, you do it the 8 hours, 2 doses before or after. It helps to neutralize derived free radicals, and then you check for other things like metformin, BUN, creatinine level. Again, I said this before, but discharge teaching. I already said this, but I'm gonna say it again. Continuous renal replacement therapy is the same thing as PERT, but if they change the name because it's 23 hours. Hemodynamic instability, you give this one, or you should anticipate the patient will be put on this one because it's slower, easier to handle. Direct dialysis, sodium polystyrene, Kxalate. Indirect, taking it, it's just an after effect that you also just happen to have hypokalemia as an effect. That's insulin, but you gotta give glucose with that, and then bicarb. Calcium gluconate doesn't affect your level. It's not indirect or direct, so do not put that if they give you the option. It's not an actual treatment of taking potassium out. It just helps with hyperkalemia in terms of the ectopic beat threshold. Um, for aortic aneurysms, basically, again, it's a bulging enlargement, ascending, you're gonna have the dysphagia. Then when you get to the thoracic, you're gonna have the back pain. Abdominal, you're also gonna have the back pain. But all of them, you're gonna have chest pain. The only difference is that with the last one, with the descending abdominal, you're gonna have sudden, sharp, shifting, shearing pain. Okay, saccular, it's a sac. Fusiform, it's all the way around. Endovascular graft, you put the graft into the stent, into the aorta. Basically, blood flows going through that, not going into the actual artery wall. Abdominal aorta aneurysm open repair. You're going in, you're putting it in there within the graft. They're going to clamp above or below. Then they're going to go ahead and put that graft in, sew it, put the vessel back around it. Boom. Now that's fixed. And then same exact thing with the thoracic one, put it in the thoracic region. And then last but not least, in terms of cardiogenic shock, you don't really have to know that much. You can read about it, but really the one thing that you do have to know is your crap. And so it's going to be you writing in contractility rate, afterload, preload. Preload also means you have to write in P part pump. Contractility, the number one medication, what are we giving? Dobutamine, then it's mirlanon. And rate, you guys know those things already. You can read about it. Afterload, to decrease nitroprusside, worrying about cyanide poisoning to help out with that. And then basically intra-aortic balloon, it inflates during diastole because it starts with an I. The deflates is the opposite of that, so it is deflating during systole. And then basically what it's helping for, diastole with inflation, it increases the aortic pressure because again it's inflated, and it helps the actual heart in terms of being perfused, so it improves coronary blood flow. And then for deflation, basically it deflates during systole because it starts with a D, it's the opposite. And then it reduces that blood pressure in the aorta because again it's deflated, but it also helps with afterload as a whole. And then that would also help to increase your cardiac output because again, more blood is being able to be pumped to the rest of the body. And then for migration, it's either going to be looking at it moving up or down. If it's moving up, you look at the left radial pulse. If it's moving down, you look at the urine output. And then for preload, the only thing you're adding for those are your diuretics and morphine, but the rest of it kind of also follows what afterload is as well. But that's literally all you would have to know for those things there. So in terms of that, that's pretty much it. So for the last like 2 minutes, let me see if there's something that I can help you guys out with because I'm trying to see if I can if there's anything else that I might have to hit on. Let me see. Another thing, yeah, I would make sure you know your leads still. So that's another thing. Make sure you go over your leads. So the AVF, like AVR, the 2, 3, V1 to V4, all of those things you guys still need to go over. So go over that. I'm like trying to think and I'm like, no, I think this is pretty much it. Yeah. Yep. I'm pretty sure that's kind of most of the things that we talked about are pretty right. Okay. Okay. Speaking of nitropicide, you guys talked about it within the afterload part, right? I talked about it. You're worried about cyanide poisoning. I think another thing that you might have to be wary of, but I don't think she taught it to you guys yet. I don't know if you guys went over hypertension crisis, um, but basically, if I don't want to say it because I don't know if she's gonna put it on here, but I feel like she would. But you guys haven't talked about it. But basically, when you talk about hypertensive crisis, you're gonna start talking about nitropicide, because you also give that, right? Because it helps to lower the blood pressure, and that's why you give it for afterload. Because basically, you're decreasing the workload of the heart by allowing by essentially affecting their BP, which allows that vasodilation to happen, less blood pressure, but also just allows for more blood flow to go and return. It just allows for that blood flow to go back to the rest of the heart as well as going to the rest of the body. But for nitropicide, yes, you worry about cyanide poisoning, but other things you might have to know is that yes, it lowers your BP because it's a venous dilator. It increases ICP, and then the one thing that you're also worried about is the cyanide toxicity. I talked about that, but other things you should worry about technically is like if they have intracranial hemorrhages because of the increased ICP, and then additionally, you're going to monitor those thiocyanate and cyanide levels. We talked about that with the cyanide poisoning. And then the one weird thing is that nitropicide has to be covered with an opaque bag. So that is another thing that I would, again, if you have to do like a little med sheet or something really quick, I would at least look up the med and kind of ask about it, just because for us, like in our exam, we went over a hypertensive crisis and cardiogenic shock and all those things. So it was easy to remember some of that stuff. But that's why I was wondering. I was like, should I tell them more about nitropicide? But worst case scenario, she won't ask, or I mean, best case scenario, she won't ask you those things. But in case she does, at least now you know if you were able to watch this last part of the video. Um, yeah, and then usually it is given through like a central arterial line. Is another thing. But other than that, that's pretty much it. The other thing I would recommend, yeah, just make sure you know your leads because I remember a lot of people like they just kind of like memorize it. So I feel like for me, because I like knew um that like I just knew them after I learned them, I kind of was like, okay, like I'm just gonna keep them in the back of my mind always. So yeah, that's another thing. So in terms of any other exams going forward, it's always the vent settings, the leads, the EKGs, the ABG, and then of course, like you guys know the ARDS, like PaO2, FiO2 ratio thing. I don't think she would ask you that on this one, but again, you never know because those are repeats. But other than that, I hope this helped a little bit for review. Again, at the end, I did go over like everything you have to know really quick, but hey, worst case scenario, if you just have to review that, you have to review that. But anyways, I wish you guys the best of luck. Thank you guys so much for your patience, and then I'll talk to you guys soon, and we'll do like an actual meeting or something. Okay.